All right. Thank you everyone for joining. So today we're joined by Dr. Allan Whitehead. He's one of our amazing emergency specialists in Australia. He has extensive ultrasound training. He's worked a lot in smaller and rural EDs, and that's where his passion lies. He's worked with Pearls before as well. He's had a few leadership roles, including as Director of Medicine Training, ED Director, and Director of Medical Services. And he's just like us, he has a strong passion for ultrasound, likes to use it on every shift, uses it handheld. Um, and he has a passion for, in particular, cardiac and lung ultrasound. But today he'll be talking to us a bit about MSK. So I'll hand over to Dr. Allan, and he can teach us a little thing.
All right. Thanks, Ethan. Um, I actually just finished a clinical shift at Hamilton Base Hospital, which is in southwestern Victoria. I'm sitting in my car if you're wondering why it looks a bit weird where I am, because I haven't had time to go back to the accommodation provided here. Plus, there's no wireless there anyway, so there's not much. I'm better off here. It's just a bit chilly. That's all in the car. So, we're going to talk about MSK ultrasound. I did a couple of ultrasounds on my shift today. They weren't MSK, but often I'm finding that I'm using it on a lot of shifts. So I'm just going to take you through some examples of where it can be used. I'm conscious about making it applicable to, um, resource limited settings. Uh, but I have traveled to those sort of countries, and in a lot of not your countries, but I've traveled to other countries, and they don't always have access even to X-ray at all, or if they do, it might be a recall situation after hours. And certainly in the hospitals I work, you would routinely have to call the radiographer in after hours to get any imaging done, which can be a big deal on weekends, public holidays, and in evenings and overnight, because you don't want to tow the radiographer out. And I'm not sure about where you work, but where we work, that costs the hospital a lot of money as well to call them in out of hours. So I think, and again, I'm not sure, again, it depends on where you work, but sometimes people have traveled for some distance, even in the country where I work, and with the expectation they're going to get an X-ray for, say, a possible fracture, and then you have to tell them that, sorry, it's after a certain time, there isn't a radiographer around, and we're not going to call them back in because it's not urgent. And it doesn't always go down very well with the parents, because often it's some kid, a little kid that's like fallen over and injured their wrist, for example. But if you can offer them an ultrasound instead and show them that there's a fracture there and it's not bad, or determines what you're going to do about it, then everyone's satisfied. Or it might be a clavicle, which you don't, usually do anything about, particularly in children. So often I find that that solves the situation, satisfies everyone, and the treatment's pretty clear. On the other hand, if the ultrasound doesn't show a fracture, then it's quite reasonable to say, well, I'm sorry, you'll have to come back the next day. But often it avoids that situation. So let's go through a few cases. So if we share the presentation.
Looks good.
Okay, all right, good. That's my email address down the bottom if you want to contact me about anything POCUS related. All right, let's just get started. So I wanted to really, I think this is fairly all-encompassing. I mean, I suppose POCUS, it's never all-encompassing. You're always finding new things to do with POCUS, and often MSK and procedures overlap, because a lot of the procedures that you do using POCUS are involving MSK applications, whether that's aspirating an effusion, or you might decide to use the ultrasound to then confirm there's an abscess and incising. You don't need the ultrasound to guide the incision, but it can help you mark where the best spot is, and also using it to inject the shoulder joint for dislocations, so that you can then reduce the shoulder, and of course confirming it's in and confirming it's out, and fractures. And there is a procedure called an ultrasound guided hematoma block for Colles fractures, which is a very good procedure. You can also do hematoma blocks at other fractures like the ankle as well. All right, so we'll take you a few picture examples really of that. Sometimes I'll remember the patient, sometimes I won't, but it's more about showing you that it can be used and what it looks like. So we'll start with some abscess stuff. So this was a guy's finger. From memory, he'd had a swollen, painful red uh, tender finger for a few days over the dorsum. And I'll just get my little laser pointer thing. Hopefully that one, because yeah. And fluid is black on ultrasound, air is white, the surface of the bone is white with a shadow behind it. So here's the bone behind. Um, One of these will be a linear picture and one will be transverse. You want to scan in both planes. I honestly can't remember which is which because they look relatively the same. Actually, no, sorry. This is one plane with a color on, and then the next picture it'll show you. I think this is probably linear because I can sort of see the bone going in a straight line here. If I was going transverse across the finger, I would normally see a curved bone. So I suspect I'm in a longitudinal plane here. Here's the ball of pus, which is obviously, quite fluidy. Usually it's irregular. Usually it squashes a bit. When you squash it, sometimes you can see pus cells floating around in it. And I think it's always good practice to then put the color box on over it and just confirm that there's no blood flow in it, because by definition, an abscess doesn't have blood flow. So if you see blood flow, definitely don't go sticking sharp objects like needles or scalpels into any lump, bump, or swelling where there's any blood flow, because you'll end up hitting a tumor or a mycotic aneurysm or something like that, and blood will go everywhere. So they should be, they should have no blood flowing into them. They might have, increased vascularity, some flashing of blood vessels around the periphery because it's inflamed and infected around the periphery, but nothing inside, which is what this is showing. And yeah, this is the transverse one because you can see the curved bone here as we're cutting across the finger. And here's the same abscess in a different plane. And the other advantage of looking at it is not only confirming that there's definitely pus, and that's a big deal because there's been multiple studies show that the clinician is wrong 30% of the time, that they think that there's just cellulitis and there's actually pus, so they haven't incised when they should have incised, or vice versa. They think there's an abscess and it's just cellulitis, but because they thought there was an abscess without putting ultrasound on, they went ahead and incised and, got nothing. And this is because the studies involved actually asked them for what they thought it was and how they were going to manage it before they had a formal ultrasound. So about 30% of the time, the clinician was wrong, and that was broken down fairly evenly to about 15% thinking it's an abscess when it was cellulitis, and 15% thinking it's a cellulitis when it's an abscess. Now, people go, Alan, oh yeah, but if I can see pus, it's clearly an abscess. Well, that's true if there's pus leaking out of it, or you can see pus on the surface. But the other thing that the ultrasound gives you is an idea of how much to expect to get out. So you can do a basic rough volume measurement, like a bladder measurement, with a depth, a width, and a height of this thing. Sorry, a depth, a width, and a length of this area, and say multiply it by 0.7 or 0.6, and then you get a rough number of mils that you expect to get out with any given pussy lump or abscess. So it allows you to be more confident that you've got out most of it. And the other thing is it allows you to tell, particularly on those ones that are areas that could go deeper, like on the torso or even in the proximal limbs. It's hard to tell from the surface, just the simple physical examination, how deep these abscesses go. It can be like the top of of an iceberg that hit the Titanic. It just looks small from the surface, but there's a lot underneath. And so it gives you a better idea of how deep it is, how wide and extensive it is, how loculated or septated it is, how thick the pus is. And all those things are very helpful in your decision making to determine whether it's something that you can realistically drain in primary care or in emergency, wherever you are in your settings, versus something that really needs to be drained formally in an operating theater because it's more deep, it's more extensive, and needs to be done often under a general anesthetic in that case. Just make sure I'm pressing the right button here. Here's another abscess. This is one of my patients. He'd had 3 or 4 days of this increasing painful red lump right next to his nipple, a male patient, and he had a good going abscess of, you can see the scale there, about a centimeter, up to 1.5 centimeters deep. You can see there's some sort of septations in it. And this is in one plane, and I've checked with the color box, and there's some blood flow on the periphery, but nothing in between. And the skin's right up here where the probe is sitting. And so I was think I was just showing you one plane there, but that's an example. Okay, so let's go on to stuff around shoulders. So this is my shoulder actually, but it's just to show you what the appearance would be from posteriorly. And so this is going to be the glenoid lip, and this is the humeral head. And this will be the way I've aligned the probe. This will be my right shoulder as I've got at the top of the screen, because I've actually got the probe marker when I'm standing. This is a posterior approach to the shoulder, so I'm coming from behind. I'm in a transverse plane. And the probe marker will be towards the patient's spine, and the non-probe marker side will be to the sort of lateral arm. And if you'd like to watch a demonstration of this, if you do an internet search and just put my name in, Allan Whitehead, and go shoulder ultrasound coach's corner, then you'll be able to find a nice 1 hour video and talk covering how to perform the shoulder ultrasound for shoulder dislocation, shoulder injection, and shoulder effusion, diagnosis and aspiration using a phantom. So I'm just keeping an eye on my charging of my phone. 1 second. Let's make sure. There we go. All right. So this is the glenohumeral space here. Glenoid lip, and that's the humeral head. So when I'm doing it, I'm looking for this curved humeral head and this sort of lip here. And often you see a bit more of the glenoid lip, but it looks like an inverted C or S shape. So any fluid looking in here. And actually my right shoulder isn't great. It's got some rotator cuff damage. And there's a little bit, this is the capsule here, this white line. You'll often see some glenoid labrum sort of sitting in here, which looks a little bit gray, triangular. But you'll see there's all black area just sitting in here, which is actually outside the capsule. So that's like sitting adjacent to the rotator cuff musculature, and indicating that there's actually been some sort of chronic injury there. A little bit of fluid, just so you get your eye in on a sort of semi-normal example. And then this is a patient that I saw who had a non-traumatic, painful right shoulder. I can't remember whether they had a fever or not. Usually I'm often doing this because they've got a fever and shoulder pain, because I'm looking to see whether there's an effusion to determine whether I can aspirate it to help get a diagnosis. And again, this is right shoulder coming from behind with a posterior marker to the patient's thoracic spine. Here's that glenoid lip again, sort of a flattened C or S shape. The curved humeral head, there's the glenohumeral space, and this is fluid lifting the capsule up here. So there's a small to moderate shoulder effusion. One of the great things about learning basic MSK POCUS, it's one of the easier, it's easy, but it's also one of the safer ones to practice, especially when you're starting out and you're not that confident, because for nearly every area of the body that you scan from an MSK point of view, there's a second asymptomatic side. There's an alternate opposite asymptomatic side. So if you looked at this shoulder and you weren't sure, is this within the normal range or not, then when you're learning, I would advocate that you do the left shoulder, same technique from behind, and go, okay, is it the same or is it different? Because if it's the same and it's the asymptomatic side, you probably don't have a problem. But if it's clearly different to the asymptomatic side, your eyes should be able to recognize that it's different, and you have got a problem. And that's really nice. The only other, there's other examples where you should do that. If you're doing renal ultrasound, then I always, as well as scanning the bladder first, I always scan the asymptomatic kidney before I scan the symptomatic kidney. This is particularly in a setting of like ureteric calculi, because it's easier to spot the mild hydronephrosis if you do the asymptomatic normal side first and get your eye in. Unfortunately, there are other organs, as we know. Eyes is another example. Again, when you're learning, it's not a bad technique to do the asymptomatic eye first, ultrasound-wise, and then do the symptomatic eye. This is particularly for non-traumatic eye complaints that we tend to use the ultrasound more, although you can use it for trauma for the eyes. Obviously, the heart, the aorta, the gallbladder, there are certain things where you just need to know what you're looking at, because you don't have a second contralateral asymptomatic comparison. Fractures the same again, sometimes if you're not sure, you can check the other side. And certainly it's a great one for checking epiphysis if you're not sure if it's an epiphysis, because you've got the other side to go to in children, or if you're not sure if it's a fontanelle on the skull, especially if it's off the midline, you can always go to the other side and make sure it's there and looks the same on the other side. Should I just go back? No, I just wanted to make sure that wasn't a clip. And here's another still picture. This is a large effusion. I remember this lady's sort of elderly, Mediterranean background, had probably a swollen shoulder. It was painful. There was a fever, moderate fever. It was actually quite hard to tell how swollen it was because she was a large lady. But this is a thing with, shoulders and hips. They're very deep joint, relatively deep joints, aren't they? So the clinical examination is not really helpful. You need to be able to either ultrasound or MRI. And obviously MRI is difficult enough to get in my setting, let alone in your settings. So ultrasound is going to be the go-to test, and ultrasound is a very good test for effusion diagnosis. There's an argument that MRI is marginally better, but it's not a lot better, and CT is inferior to ultrasound, and X-rays is much more inferior to those other modalities. So this time we've actually got the left shoulder from behind here in a transverse plane. Here's that glenoid lip again coming down into the articular surface of the glenoid fossa. You won't be able to see all of the glenoid fossa because the sound waves can't get all the way in that gap. And here's part of the curvature of the humeral head. And there's a nice thick amount of fluid from a shoulder effusion coming out of that joint and pressing up against the capsule. Now, seriously, it was extending out about that far on this side and about that far on this side. So I didn't need to guide a needle in to tap this fluid. I could easily just X mark the spot. I didn't need to be very precise. And from memory, it was either gout or pseudo-gout. It wasn't septic, but often when you're aspirating these joints, it's because they're febrile and you're not sure if it's septic or not, and you need to rule that out. Now it's the picture's off to the side. So this one, the sonographer's actually taught me this. And there is actually a way that you can screen for shoulder effusion instead of coming from posteriorly behind the shoulder, a posterior approach. You can actually look at the long head of the biceps in the bicipital groove. So usually get them to rotate their upper limb laterally, and then the bicipital groove will face outwards, and it's easier to get at. And so the bicipital groove is sort of sitting in here, and then there's a tendon sitting in here. And what you're looking for in that tendon is fluid around the tendon. There's no fluid around this tendon, but it'll be encircled with a black circle and grey within it if there's an effusion. So that's a nice quick screen to tell whether there's an effusion or not, because the capsule envelops all the way down to sort of like the proximal extent of the bicipital of the long head of the biceps. So if there's any fluid in the shoulder joint, it does track down into this area. I don't use it much. I generally just tend to go straight for the posterior approach to the shoulder to look for an effusion, but certainly it's a recognized technique for that. There's a little bit of wordy stuff here. So when we are taught, and you may have all been taught in medical school or as junior doctors, not doing ultrasound, and I'd done over 100 knee aspirations or knee taps without ultrasound before I even had an ultrasound in my hand about 20 odd years ago. But and they teach you to do, either a medial approach or a lateral approach and feel the joint margin, but it's not a very patient-friendly technique. That's part of the issue I have with it, and certainly radiology people and sonographic people back here in Australia, they're a bit horrified about when doctors talk about blindly doing knee taps, because it can be quite painful. If you're doing it, you're often deliberately bringing the needle into the patella as your first movement of the needle, and then you're basically searching under the patella. So you're stepping down, deliberately sticking the needle into the kneecap, the patella, and then going under it from either the medial or lateral side. And often then you still end up poking the tibial condyle or the cartilage or the femoral condyle. It's not a very patient-friendly procedure. It doesn't matter how much anesthetic you squirt in, it still can be quite uncomfortable. So that's one issue with it. And if you do a suprapatellar approach where you're coming in the midline above the patella and aspirating from the suprapatellar pouch, then it's actually much more patient friendly as long as you don't insert the needle through the quads tendon. Because there's two reasons they'll jump with a suprapatellar approach, which is how they normally do it in radiology, is they'd only jump if you put the needle through the quads tendon or if you actually stick the needle in too deep and you hit the femoral shaft. But I'll show you on the ultrasound, it's easy to see the quads tendon, it's easy to see the femoral shaft, and you can X marks the spot to make sure you avoid the quads tendon, or you can palpate the quads tendon and make sure you're just to the side of it when you put your X on. And you can see how many centimeters you've got to go down to hit the fluid without hitting the bone behind it, the femoral shaft, because you can see that on the ultrasound how many centimeters it is. And you'll be able to judge roughly, is it small, is it moderate, or it's large. In anatomically, they say about 90% of the time the knee joint is communicating with the suprapatellar space or pouch. So that's why the idea is, instead of trying to get the needle into the joint space, you can use the presence of the fluid in the suprapatellar pouch where it's easier to get out and it's a more patient-friendly procedure. And if it's a small amount, I generally will compare to the painless side, especially when people are bigger or they're older, because they often have some wear and tear in their joint and they will get a small amount of fluid in their knee joint. So if it's the same on both sides, I'm not particularly keen on going in and aspirating. But if it's markedly different on the symptomatic side, if it's markedly worse, and I'm concerned there's a possibility of septic arthritis, it might be particularly because they've got a fever, and particularly if they're unable to move the joint much because it's very, very painful, or if it's the knee, they can't walk on it. All those clinical things that I think increase the risk of it being septic arthritis, then this is a technique to use that's very patient friendly. And in fact, I've actually got a small amount of fluid in both in both knees in terms of the suprapatellar pouch, but I've never had a symptom of pain in my knee in my life. So again, don't get too overexcited about a small amount of fluid in the knee. Something like this, a small amount of fluid. This is actually the not the meniscus, the cartilage lining the femoral condyle. That's not fluid. There's a little thin membrane that the ultrasound's picking up, and the fluid's actually lying on top of that cartilage membrane. And you can tell that it's that because this if there's two layers, one of them has to be the cartilage. But even if you only saw one layer and you didn't see the fluid sitting on top and you only saw this bit underneath, cartilage doesn't compress. So the test is, if you're thinking you're seeing your fluid, you must squash down on it just like you would with an abscess. You squash down on it, and if it pancakes and flattens out and changes shape, that tells you that it's fluid in the suprapatellar pouch in this area. Whereas if it stays very consistent thickness, doesn't change shape, then that tells you that's the cartilage. Remember, the cartilage is 98% water, so it's going to look very dark, very echolucent or black on ultrasound. I'll play I think this is a clip, or maybe it's the next one is a clip. Thought I had one clip here. Hang on. Just let me come out of that. Go away. Just want to turn that off. That's good. Should be able to get out of it. That one. I'm just turning the laser pointer off. Oh, here we go. I thought I had clips. You can't laser. I always learn things on PowerPoint. You can't laser pointer and press the clip at the same time. Okay, so this is the femoral shaft. Usually I'm trying to identify the superior pole of the patella first. So I'm placing my probe, my linear probe, my superficial probe in the midline, and I want to feel the caudal end or the inferior end of the probe literally touching the superior pole of the patella. And therefore I'll see this curved bone, which is the patella with a shadow behind it. And then there's a tendon, the quads tendon, which is this fibrillary appearance from about here to here, and you can see it's got lots of fine lines in it, and it's actually narrowing, and it will insert into the patella. That's the quads tendon. I can identify with the ultrasound, but I don't want to put my needle through it. So when I mark, I've got to make sure I move to the side enough that I don't see this layer. It all disappears. I would never try to tap something this small. It's just not going to be something of concern. It's got nothing to do with the patient's symptoms. It's an incidental finding, particularly if you see it on the other side as well. And we'll play the clip again. And I'm following it up, and you can see it just edges away from the bone a little bit here. I would still grade this as small. It's a qualitative thing. Anything that's roughly the width of a probe is about, I would say, about small. Anything that's up to the width of two probes, not width, the length of two probes. Oh, I suppose it is the width, that that broadest side of the probe. Anything that's as I'm in a long plane, it's occupying that up to two widths of the probe. So that would be, I'm trying to remember, Steve would know better than me who's on the call what the width of your standard linear probe is, but I'm guessing it's probably about, what, 3 centimeters, Steve? Or maybe 4. God, to be honest, I haven't measured. Actually, it might even be more than that. Might be 5 to 6. I think it's 5 to 6. So anything that's probably around 10 centimeters, I would grade as moderate. I think we've got an example in the next one. There we go. Go. So here's one that's a bit bigger. Oh, yeah, I'll just try and play the clip. Is that a clip? Oh, that's a still. So here's the patella. Here's that quads tendon again. And this one, here's the start of it. So my three landmarks are patella, curved bone. This is the superior pole area to here. The quads tendon is my second landmark. And my third landmark is the femoral shaft at the back. I want to note how deep the femoral shaft is as well, because if I stick it in 4 centimeters in this patient, I'm going to hit the femoral shaft and they're going to jump. So I've got to make sure that I stick it in. Where's my sweet spot here? It's about 2 to 3 centimeters, 2.5 to 3 centimeters, how far I want to insert the needle. And it's the same direction as I'm pointing the beam. And then I've slid up the bone a little bit, so I've slid up that way. And you can see it's tracking up further. So this is probably about 2 probe widths in size. So I'd sort of say it's around a moderate size, just migrating. And then here's a large one. And this one I can tell you, I've only got one picture here, but I can tell you it was going up almost to halfway up the femur, going a long way. So the bigger they are, the more they follow the femur, the femoral bone upwards towards the hip. And the other good thing, the other reason to aspirate clinically, you'll know this anyway, there's 2 reasons. One is if you're worried it's septic, but the other one is to give the patient relief of pain. Because if it's a big effusion like this knee or the shoulder one that I showed you beforehand, they can be taking quite a lot of painkillers, even when it's like gout or pseudo gout or rheumatoid, whatever it is. And they're just not getting much relief, but because there's such a volume of fluid in the joint that it's stretching the capsule and causing a lot of pain. But if I can suck out 20 mils of, serous, sticky fluid, even though it's not pussy and septic, if I can suck that out, 20 major joint like the knee or the shoulder, then they can get a significant amount of pain relief. So that's another reason to aspirate the joint. It's just saying my internet connection is unstable. Can you still hear me okay?
Yeah, you froze for like a fraction of a second, but you're fine now.
Okay,
It's
all
all
right.
good now.
Back on?
Yeah.
Okay, good. Sorry, this is the problem when you're working in a place that doesn't have good wireless, which I'm sure some people on the call are familiar with. So now we're down at the ankle. You'll notice this is also in the sagittal plane, like in the midline. It's a pretty straightforward one to do as well. I think the knee is quite straightforward. In the midline, anteriorly touching the superior volar patella. The ankle is similarly fairly straightforward. You just look at the front of the ankle, and you want to place it halfway between the medial malleolus and the lateral malleolus, so perfectly where you think the midline is. Remember, as per normal convention, if you're scanning in the sagittal plane, which both of these techniques are, the probe marker should be towards the head. So this is going to be the proximal end here, where the tibia is, and I'm just following the bone down, and I can see it curve. So I'm right on the end of the tibia here, and I'm actually looking for a valley effect. So this is the talus coming in as the next bone distally towards the feet. So when I'm scanning, I'm looking for this valley effect of bones and any fluid coming out of the valley, because the ankle joint's sort of sitting in here. And as the fluid builds up, apologies, I forgot that you can't see that unless I put my laser pointer on. Hang on, 1 sec.
We can see your mouse.
Oh, you can see my mouse? Excellent.
Yeah, we can
Then I
see.
won't bother with a laser pointer. So, if the fluid's sitting in here, and as it gets bigger, it'll spill out, and you can see it spilling out along the talus here. So that's an ankle effusion. You've got your diagnosis, and they're quite close to the surface. Obviously, most people, unless they've got really big ankles, so it's not that hard to X marks the spot. You don't really need to guide the needle in my opinion. You can just X marks the spot over it because look at it. It's only about a centimeter half deep to the fluid. So just a nice little, 3 to 5 mil syringe with a 23 or 25 gauge needle, and you'll get that quite nicely. And you're not going to suck out a massive amount of fluid like a knee or a shoulder, or sometimes a hip if you do those. It's going to be, it's going to be, if you get ankles and wrists, if you get out, 1 or 2 mils, you're very, very happy. Even half a mil might be all you get out. But that's enough to make the diagnosis most of the time, wherever you are. Just making sure I'm pressing the right button. We're frozen. One sec. Do that. Here we go. Here's another example of an ankle effusion. You can still see my mouse.
Yeah, we can still see it.
Great. Okay, good. So again, following the tibia down. If you're having trouble seeing the tibia in long axis because it's curved, my tip is if you're trying to see the bone in long axis and you're having trouble seeing it, start in transverse plane, short axis on the bone, and then you'll see the curved bone much easier. Get the curved bone in the midline of the picture and then rotate 90 degrees onto it. And then fanning back and forth, so that tilting of the probe if you're having trouble seeing the white line of the bone. But if you do the curved bone in short axis first, you know the depth of the bone and it's easier to work out if you're looking at the right thing. So following that tibia bone down, it's dropping off at the end of the distal tibia into the valley. Here's the talus, and there's fluid coming out of this valley, probably more fluid in this one, and pushing up on the capsule. This is probably the capsule membrane there. I can't remember. I can't actually remember whether we aspirated this one or not. But oh yeah, my recollection is we probably didn't. My recollection is that she'd actually had, it was probably like either a rheumatoid or a seronegative polyarthritis, a seronegative arthritis type of problem, because she'd actually had joint pain in the wrist about 2 weeks earlier, and then that had settled, and then this one came on. So clearly, probably less likely to be a gout or a pseudogout, which are classically more monoarthritis, and don't tend to affect multiple joints at the same time or close to the same time. This wasn't exactly the same time, but it sounded more like a polyarthritis problem. And she was female and she was young to middle age, so that's what we expected clinically it was going to be, and put her on appropriate treatment for that and asked her GP to organize some more tests, particularly around serology tests. Okay, this is an elbow. This is probably a little bit more tricky. So this is the posterior approach definitely here, and I think another posterior approach here from memory. And remember, and typically you're scanning in a sagittal plane first or a longitudinal axis, because that's a little bit easier using the olecranon as a landmark. This guide had a sharp metal, like almost needle from a sheep's comb. I don't know if people are combing sheep where they are in the Pacific Islands, but he had this very long, rusty sheep comb that's about 5 times as long as a normal comb, and one of the spikes spiked him in the elbow. And it went in a few centimeters, and I think it actually caused a septic arthritis in his elbow. And so he came in 24 hours later and was looking pretty angry. He was febrile. And so this clip that's replaying, here's the olecranon curving, and you can see musculature coming off it. And there's the effusion. Remember, fluid is black on ultrasound. And so this is likely the humerus here, and then as I said, the olecranon here. We're looking posteriorly here, and again, same view, but if you look really carefully, look at that fluid there. You can actually see little white dots in it, and when I pressed a little bit, you could actually see them moving. So he had visible pus cells in the fluid. If you see plankton, what Daniel Lichtenstein calls plankton, which are little white dots floating around in fluid anywhere, whether it's pleural fluid, acidic fluid, joint fluid, it means it's an exudative process, which is supporting what I thought was my diagnosis of septic arthritis. So he got referred off to orthopedics. This was a younger patient, not an adult this time, a child, and she fell over and had some pain and swelling. And this is a posterior approach here. So this was, where are we? So let's play it. We need to play the clip to see it a little bit better. So it was a posterior approach on the left-hand side of the screen. So this was the humerus that was here at the start of the clip, and this is the olecranon coming in here now. So this was humerus, olecranon, and there's some fluid sitting in here posteriorly. And then I went into a more of a short, still long axis, and I went anteriorly, roughly in the midline, and you could see the fluid anteriorly poking out as well through the joint spaces between the ulna and the humerus. I'll actually play that for you, sorry. So I think this is epiphysis here. That's the distal humerus. That's the epiphyseal line and the epiphysis. And that's the sort of the anterior lip of the ulna proximally. And there's fluid on both sides. When you see fluid, setting of an injury, that means that, even I can't remember if this kid ended up having an X-ray at some stage, but this is similar, effect to seeing the sale sign anteriorly and posteriorly on an X-ray. It's basically the same phenomenon, and it means that if you see it posteriorly, you've got about an 80 to 90% chance of having a fracture there, even if you can't see it. So an occult type of undisplaced fracture. If you see it anteriorly, it's about 30 to 40%. So the fact that we're seeing this, particularly the posterior one, means there's a high probability of a fracture. Even if you can't see it on X-ray, there's likely an undisplaced one. That's fine. If it's undisplaced, nothing needs to be done. There was no features on the ultrasound to look like the bones were displaced, but it's still going to need to be immobilized for, at least a couple of weeks, maybe longer, maybe, up to a month. Assuming it could be an undisplaced supracondylar fracture or an undisplaced epicondyle fracture or an undisplaced radial head fractures. All these things could cause fluid in the elbow joint. We're at the wrist now, still on effusions. And this one, we did aspirate, turned out to be gout. And the interesting story was that it was precipitated by some minor blunt trauma, but he also had a history of gout. And it was a day or so, but then it started to get very sore over the subsequent causing it, although a sprain of some sort could do it. But he was very stiff and sore. He could barely move his wrist joint, which wouldn't really fit that much with a sprain. So I'm sliding down in the midline, in the long axis on the bone, coming over the distal radius, and here's the joint space here, the radiocarpal joint, and you can see this fluid again sitting in this sort of V-like valley. And I think that's just a still picture there showing the same thing. And so with his past history of gout and the story, I was suspicious that it was a monoarthritis precipitated by the blunt trauma. So I think from memory, he got some X-ray imaging as well as ultrasound, and neither showed up any fracture. And he responded nicely to gout treatment. Let's have a look at dislocations. I'm just having a look at the time. Oh, we're getting on. Okay. We've only got a couple of slides on dislocations, then we'll look at fractures. So the one I'm mostly using it for is shoulder dislocations, but any joint, anywhere, ultrasound is really useful because it's very good at perceiving depth. So you can look at whether one side of a joint levels up with the other side of the joint, even in trauma and major trauma where someone can't walk in and you're worried about major trauma and maybe a very bad pelvic injury, you can actually put the either the curvilinear probe or the linear probe over the pubic symphysis. Typically, we're using the curvilinear probe, which is what we're using for our fast scan anyway, and we literally pressing it over the pubic symphysis in a transverse plane, and you can actually see the the superior pubic ramus on both sides, and whether it's got a step in it or it's widened, which is if it's abnormal, then it's highly suspicious for a major pelvic injury like that open book pelvis injury, often associated with severe retroperitoneal hemorrhage. But it's also good for, as apart from shoulders, sternoclavicular joint, AC joint. I'll show you some examples. So this is my sternoclavicular joint. It's actually normal. And just as an example, and it's very easy to do. And again, you've got an opposite side to compare to. So we're transverse plane over the sternoclavicular joint. We want one side of the linear probe over over basically the manubrium, and the other side over the proximal end of the clavicle. And so this is the proximal end of the right clavicle. Here's the manubrium or body of the sternum. And we can see and here's the skin. So there's no question of this being dislocated from an injury. I think that the patient had fallen and had pain over the sternoclavicular joint, and there was a worry about whether they were dislocated. And you can see it's very, very level. Now, it might be 1 or 2 millimeters of difference. It might look like there's a tiny bit of difference, but if you look at the scale, it really translates to only 1 or 2 millimeters. So it's very much aligned. And I think from memory, this patient actually, when we imaged with ultrasound and X-ray further up, sorry, with X-ray, you couldn't actually see anything. But with ultrasound, you could see that he had an undisplaced fracture of the proximal end of his clavicle. But we were double checking the sternoclavicular joint and it was fine. X-rays are useless for sternoclavicular joint dislocation because you can't get in the right plane to tell whether it's anteriorly dislocated or posteriorly dislocated. So, and even if you have access, you've really only got two modalities to be able to tell whether it's dislocated. It's either ultrasound or CT. CT can tell you that whether it's dislocated anteriorly or posteriorly. You really need to know whether it is, because a posterior dislocation can cause pressure effects on the mediastinum. It can cause edema, tissue swelling, and it can be quite dangerous to the patient. Whereas an anterior dislocation of the sternoclavicular joint is very benign, and they usually just let it they manage it conservatively and let it heal itself. Whereas a posterior sternoclavicular joint dislocation requires surgery. But an X-ray is impossible to tell which it is, or even if there's anything there at all, whereas an ultrasound can perceive this depth change very, very well. And as I said, you can always compare to the other side. Here's my AC joints. Not only is my right shoulder a bit stuffed, my right AC joint is in fairly poor condition as well. So if we look at the left, where's the left side? Okay. Oh, actually, this isn't mine. Mine are coming up. I was wondering, that's weird because the right side looks better than the left side. This is a patient's one. So this one, they had a left AC joint injury, presented with some sort of trauma, and it's painful and tender over the AC joint. And so the asymptomatic right side, you can see, it's lining up pretty well. This is sort of a fairly normal space. And again, if you're not sure, you've got this asymptomatic side, so it's probably what normal looks like. And here's the symptomatic side, the painful side. Look at it. It's elevated. There's a clear step between the clavicle, because remember, probe marker's on the patient's right. So this is clavicle and acromion on the left side because we're coming from anteriorly. And this is acromion and clavicle on the right side. So the clavicle is lifted up compared to the acromion, or the acromion is dropped down compared to the clavicle. There's a definite step, and it also looks widened. So it's likely to be a grade 2 AC joint injury. This one is my AC joint, which makes sense because my right one is not in good condition, has some intermittent pain issues. And looking at it, let's look at the normal side, the healthy side, the asymptomatic side. Nice, clean bones, no lumpy, bumpy moth-eaten, degenerative, irregular-looking bones. Look at the unhealthy bones of the AC joint here, really irregular. And even the amount of fluid coming out of the joint and running along the bone. This is the asymptomatic side, okay? Look at the symptomatic side. There's a similar amount around here, but look how much it's tracking along the bone. It definitely looks like it's tracking along the bone on this direction. So there's a little bit more fluid in this joint as well. This was just a chronic injury. This wasn't, an acute AC injury, just chronic damage. Again, just not rotating, sweeping the probe around the joint a little bit just to get a couple of different pictures of the joint. And when I did that, it sort of on a more so I think it was a more superior approach. The bones actually looked a little bit cleaner on this side, but you could certainly appreciate that there was more fluid contained on the right side than the left side. Whenever you're scanning bones for fractures, in particular, less so for effusions because there's usually a set spot you look, but for fractures, it's really important to be sweeping all the way around the bone in long axis, particularly when you're looking for, when they're looking for undisplaced fractures, you're looking for a little, just a simple break in the cortex, or sometimes, in kids you get that green stick bump, that buckle, and you've got to look all the way around the bone, just like in an X-ray. You never order one view; you always order two views, a lateral and an AP, because sometimes the cortical breach or the bump is only visible from one direction. It's the same with ultrasound. But the advantage of ultrasound is you can get all the way around the bone, which is nice. All right, so this is a normal looking shoulder. And again, giving you a bit of an idea of that. I think probably in the interest of time, I won't go speak to about injecting the shoulder, but I'll show you a couple of pictures of what a dislocation looks like. So this was a anterior dislocation, which, as we know clinically, is way more common than a posterior dislocation. And we're coming from behind the shoulder. So it's exactly the same technique as looking for an effusion in a transverse plane. So the great thing is if you learn how to do a posterior approach of the shoulder, you can use it for effusion diagnosis. You can use it for dislocation and relocation diagnosis. You can use it for injecting the shoulder. Learning one technique allows you to have more like 3 different applications for it. And so this is a dislocated shoulder anteriorly. Here's the humeral head. And remember those pictures before where the glenoid is lining up fairly evenly with the humeral head. Look at the big step up here. My probe is behind the patient. So if it's stepped all the way closer to my probe, that means that I've got, actually, hang on. So wrong way around. I'm describing this the wrong way around. My glenoid is here. That's the static thing. The humeral head is the one that moves. So what happens is I'm looking at my glenoid. That's the static thing. I'm coming from behind the patient. Apologies for that. Behind the patient. Here's the skin. And my humeral head is moved all the way forwards towards the anterior part of the patient. So this is posterior, this is anterior, and there's a massive step down because normally it's fairly even. The humeral head would be sitting here. It's moved significantly forward a few centimeters. If it's more than a centimeter down from the humeral head or away from the humeral head, it's definitely abnormal. So this is a couple of centimeters down from the glenoid. If it's moved down from the glenoid a couple of centimeters, definitely abnormal. Here it is. I've done my reduction, and then up it comes, and it's a lot more level with the glenoid. So here's the glenoid, there's the humeral head. So I'm happy I've relocated it, and I can tell that without even waking the patient up if I put them asleep. It's different if you're doing it without giving the patient sedation. They'll tell you whether it feels better, but if they're asleep, they can't tell you it feels better. Sometimes you don't get a good clunk. Sometimes they've got big shoulders. It's very hard to feel the anatomy. So being able to double check that is really useful, especially if you put the patient asleep and then you wake them up and you x-ray it and then you realize it's not back in. It's a heart sink moment to have to do it again. And this is a posteriorly dislocated shoulder. So this is the opposite, that very rare situation, 1 in 100. This guy had a fall, not the typical classic mechanism. He just had a fall and he came into ED, could barely move the shoulder. And this one is, again, the right side. We're coming from behind. Here's that glenoid lip. and there's the humeral head, and you can see this time it's much closer to the probe. If my probe is coming from behind the patient posteriorly, that means the humeral head is moved towards the probe. It's moved posteriorly in relation to the static glenoid. So this is a posterior dislocation because it's moved a couple of centimeters forward of the glenoid. And it's because it was so rare, I did an X-ray just to double check. And you could see on this X-ray, if you look at it carefully, there's the glenoid fossa. This is posterior. This is anterior, so it's definitely moved posteriorly. And you can see it's out. It's not touching the glenoid fossa properly there. So posterior dislocation on ultrasound confirmed on X-ray, if you want to double check, which I did. And then we did our maneuver. It was a big effort to get it back in. Took 3 different attempts with procedural sedation, 3 different types of maneuvers, but eventually got it back in. And you can see it's in a little bit better position now. It's not quite as far advanced as it was before. It still might look like it's a fair bit above the glenoid, but the other thing you can do is you can get the patient to move their arm, or even while he's asleep, you can rotate his arm, and I could see it staying very snug to the glenoid. So I was happy that it's definitely in. And we had the X-ray, and again, that backs up what my ultrasound is saying, and you can see an improvement back to normal with the X-rays there. So let's look at some fractures. This same patient, when I did the ultrasound post-reduction and I'm scanning the humeral head, I could actually see some impaction fracture in the humeral head. So you can see how sensitive undisplaced fractures are when you're looking with ultrasound. I'll skip over the injecting the shoulder. If you want to look at the video online, I go into that as well. But there's some points here. Let's look at some fractures quickly, and we'll just have a look at some examples. I would make a comment that if you're looking for skull fracture in kids, don't look just in the center of the hematoma. Make sure you look on the margins of where the hematoma is as well, because sometimes the fracture line is not perfectly in the center of the hematoma and it might be on the margins. So if you're scanning for a fracture, look all over, but make sure you scan to the edges of the hematoma. It works brilliantly for sternum fractures and clavicle fractures and long bone fractures. It's very good for most fractures. Probably the only ones it's not really that great for is things like spinal fractures. Let's have a look at some examples. These were 2 different teenagers. Both had delayed sort of diagnosis, delayed presentation diagnosis. I can't remember which is which. They were both rugby injuries. One actually presented 3 or 4 days after the injury, hadn't seen a doctor yet, and was complaining of ongoing pain. We X-rayed it, couldn't see anything on the X-ray. It was reported as normal subsequently by the radiologist, but we asked him to point where it was, and you could see the fracture clear as day. It was one of these 2, but you could definitely see exactly where he was pointing. And then the other one actually had presented quite timely in the first day after the injury, had an X-ray then, was also reported as normal, then had ongoing, was told everything was fine, had ongoing pain, represented several days later, and I ultrasounded it, and again, you could actually see clearly where the fracture was. So this is, and is it important? Well, you're not going to do anything about it per se, but they all wanted to play rugby the next day, which I'm sure some of you in the Pacific are familiar with, the passion for rugby. And it was a lot easier for their parents to convince these 12 or 13-year-old teenagers that they shouldn't be doing that for the next month or so, given that it was proven that they had clavicle fractures, because up to that point, there was actually no proof that they had clavicle fractures. And they could have obviously done more damage and made it more displaced and, just delayed healing. And so that's not a great outcome. We don't want that. So we were able to stop them from playing their sport tomorrow. Here's another clavicle fracture. This was, I think, fell off a trail bike. And again, nice example there. Very easy to see. Make sure you scan all the way around the bone, So anterior aspect, superior aspect, inferior aspect. You can't get to the posterior aspect, but you can get to all 3 other sides to make sure that you're not missing a fracture. And here it is on the X-ray, so you can see it corresponded really, really well with the ultrasound picture. I wouldn't have normally ordered the X-ray, but someone did it, and I just thought it's great educationally to show you how closely it represents the X-ray picture. And this was a quad bike injury, and X-ray had gone home, and I said, look, I can ultrasound it to prove you got a clavicle fracture, and I showed him the pictures. He was very happy. we said this is how we're going to manage it. We're going to manage it conservatively, and he didn't need anything else done except the usual conservative management. And so he didn't need to come back for an X-ray. The next day he was very happy as long as he'd seen the fracture with his own eyes. A nursing home patient who fell over, and she was sent in as a dislocated shoulder. She couldn't give a history because she was demented. There was some yellow bruising around the shoulder. Um, most of you will realize that you don't normally get bruising with a pure dislocation. So that would be unusual. So I was already thinking this doesn't seem like a dislocation because the bruising and also the fact that it probably happened days ago, because it was yellow discolored. And I thought this is much more likely to be a clavicle fracture, or maybe a humeral neck fracture, but it was actually more over the acromion area. So let's put the ultrasound on. Let's look at the ultrasound first. Here's a still picture, and I'm sliding along the clavicle distal, and here's a nice break in the bone. You can see the breach here. So that's the distal clavicle there with a breach in it. And I didn't actually order the x-ray, someone else did, because I don't normally order x-rays if I can see the fracture on ultrasound, especially if they're going to be conservatively managed, but someone at triage had already ordered one. And you can see again, it corresponds really nicely with the appearance on the ultrasound. And guess what? The radiologist missed it. I followed up afterwards and they said it was normal. And clearly it's not. Some sternal fractures. It's a brilliant modality for sternal fractures, and particularly for undisplaced fractures. It'll see it when you can't see it on the sternal x-rays often, particularly in elderly people where there's a lot of degenerative change. It can be very hard to see undisplaced sternal fractures, which can cause them a lot of pain, and sometimes there can be complications like blunt hemopericardium, cardiac contusion, even though they're very rare, for which learning cardiac ultrasound is useful. And the other thing is, even if you have access to CT, there's definitely documented cases where, because the CT is slicing, the CT won't pick it up. And I'll show you an example in a second. So this is some obviously gross examples of sternal fracture. And here's the fracture fragment with the proximal part and a distal part. And here's the fracture in between. These are very easy to see on ultrasound. Doesn't need any skill at all. Often having overlying hematoma, which is why it's darker here, which is a visual clue, especially around undisplaced fractures anywhere. If you see a darker area above the bone, look really carefully, because often that means there's a little undisplaced fracture or cortical breach there. This was a girl that was in the ruck playing AFL football and got knee to the chest jumping up in the ruck. And you can see in the body of the sternum, she had a nice little crack in the sternum there, undisplaced. And this was the one that actually had a pan CT the day before, after a fall. I came to see her in short stay where they observed people overnight because she was in a lot of pain that morning, couldn't even move out of the bed, the poor little old lady. And I asked her where the pain was, and she pointed with her finger at a particular spot on her sternum. And she'd had a CT the day before, which had been reported by the radiologist as normal, no fractures anywhere, nothing, no injuries anywhere. And I looked at the CT films, I couldn't see anything either, but you could see the fracture as plain as day on the ultrasound. And remember, if the CT's slicing here and here, like 2 millimeters apart, and it's a transverse fracture across the sternum, it is literally not going to see the fracture when they're laying on their back. So then we had the diagnosis, and we could offer her more pain management, and we knew why she was struggling to get out of the bed. Rib fractures take a bit more skill. This is an elderly patient, and again, scanning along the ribs, you can see some nice, fairly sort of undisplaced fractures, a bit bent but undisplaced. These are my rib fractures, just to show you. From karate, obviously need to get better. Being belted up by a few other people in class in sparring. So here's one occasion, one rib. And this is me scanning myself with my own ultrasound machines. Again, you would struggle to see that on X-ray, and sometimes you don't even see these on CT because, again, slicing can miss it if it's not perfectly, if it's above and below the rib fracture where you're slicing. And this was an occasion when I actually had 3 rib fractures. So there's one, there, and there. And above it at the 10th, and you can assume if the 8th and the 10th are done, there's the 10th. then the ninth is done as well. So I had 3 undisplaced rib fractures. I always scan the lungs. That's all. The most important bit, making sure there's no hemothorax, pneumothorax, or lung contusion. So part of your E-fast scan, your extended fast scan. I can assure you I scanned the lungs and they were fine. And lastly, to finish, some green stick buckle fracture examples of people falling, kids falling over, whether it's rollerblading or monkey bars or trampolines or whatever, or just running around. So here's one example, nice little buckle fracture there. They always look big because look at the scale, it's 1.8 centimeters to the bottom of the picture. So this is really a buckle of only like, I don't know, 3 to 4 millimeters, but a clear, nice example. It looks no different to if you're looking at an X-ray, a lateral X-ray, for instance. It's just that you only see one side of the bone. You can't see the other side of the bone because the sound waves can't get through. This is the epiphysis. How do I know? Because it's got a fairly smooth edge here. There's no hematoma over it. That nice curved edge is consistent with an epiphysis. And if you weren't sure, you can always scan the other side and you'll see the same on the other side. Here's another example of a distal radius fracture in a kid. This one a little bit worse because you can see it's not just a cortical bump, a torus or a green stick fracture. The cortex is actually broken here. And a couple of shots of that with some, tendon and muscle over top. And you can see a little hematoma next to it as well. So this one had an X-ray, came back the next day for an X-ray because we're not going to be able to manage this quite so straightforward. Probably needs some orthopedic follow-up. And you can see it corresponds quite nicely with that was the dorsal side I was looking at. It corresponds quite nicely with what I'm seeing on the ultrasound. And I think this is the last fracture. And this was again, this shows the fallibility of X-ray. You just got to understand, even if you have X-ray, it can miss things. So the clavicle fractures were missed on X-ray. This was a proximal tibia fracture that was missed on X-ray, as in you couldn't actually see it on the X-ray. It wasn't reported by the radiologist. It was reported as normal. Although really looking critically, with I think you could see a little bit of evidence of it there, but the radiologist reported it as normal. And then she still wasn't walking on it, this kid, after the fall. This is 24 hours later. So I put the ultrasound on it. We're in the proximal tibia area. So hit the knee joints up here. This is the epiphysis and metaphysis. And you can see, so we're following the proximal tibia down, and there's a nice little, I think if you look critically with the ultrasound, you could just, with the X refusing to walk, and she needed plaster immobilization and non-weight bearing for that. So it obviously changed her management. And sorry, probably just, my internet connection's just gone a bit wobbly. Can you hear me again? I might have gone a bit wobbly. I'm just wrapping up here now. And there's a metacarpal shaft fracture and a finger in the long axis, just sliding along the metacarpal bone, distal, that'll be proximal end, distal end, and you can see the step. These things are not hard to see. And I won't spend time on the ultrasound guided hematoma block. Actually, in terms of describing it, but I'll just show you the picture, the clip, because it's really nice and neat. So here's the X-ray of a Colles fracture in an elderly patient who had a fall. You can see it's dorsally displaced and dorsally angulated. There was no room in the ED for her to have procedural sedation or a Beers block, or we call what's another word for it? Like any sort of like a regional anesthesia technique. And so wherever they are, whether it's on the ambulance, trolley, or in our fast track or short stay area, we can do things like inject the shoulder for a dislocation and then reduce it. Or we can do this technique called an ultrasound guided hematoma block and introduce the needle in the gap between the 2 bone ends. So here it is. Here's the needle shaft coming down. There's the proximal end of the bone. There's the distal end. There's the gap between the bones. I'm coming from dorsally. And if you watch here, there's a bit of contact on the gel. But if you watch around here, you'll see a needle tip just come in there. There's the needle tip right there. And injecting about 15 mils of 1% lignocaine. You don't need to be too fancy. and so I'm aspirating first to make sure it's blood because it should get blood in the from the hematoma, and I'm injecting. You can see a little bit of the fluid, the anesthetic's leaking out, or my needle might have dislodged a bit. But they always say that a lot of volume solves a lot of things. So I made sure I injected a good volume, and then waited 10 minutes, and she had very good anesthesia, and we were able to reduce that with the two of us, and re-ultrasound it. That's the great thing about ultrasound. Put the ultrasound back on, and you can see I'm sliding down the bone from distal to proximal on the dorsal aspect in long axis plane, sagittal plane. And the fracture was literally about there. And you can see it's much better now. You can't even see the fracture anymore. Here's the wrist joint. So that was much, much better. And proof is in the pudding. Here's the X-ray, and you can see, that dorsal displacement and dorsal angulation is corrected. Everything is in a nice straight line with a plaster on. So very, very good result. And we're done. Sorry, I went a bit over time.
No worries at all. Thank you so much, Alan.